Welcome to Dr. Brian Lippincott's lecture on applying solution-focused brief therapy, or SFBT, to addiction studies. Traditional clinical models often treat addiction as an archaeological dig. They focus on excavating past trauma to find the root cause of the pathology. SFBT flips this axis. It focuses entirely on the client's desired future and the competencies they already possess to get there. This approach is built on Occam's razor, the idea that we should make the fewest theoretical assumptions necessary. In practice, this means employing minimal intervention. We deal strictly with the observable behaviors the client presents, rather than going out of our way to assign a diagnosis or look for trouble. We see this applied directly in the addiction field through the Bruges model. Instead of isolating and pathologizing the individual, the clinical focus broadens to improving their immediate social conditions and amplifying their positive relationships. The core premise here is straightforward. Understanding the origin of a problem is not a prerequisite for solving it. You do not need to uncover the root psychological cause of a substance use disorder to co-construct a viable, lasting solution with the patient. To build those solutions, the traditional clinical hierarchy has to be dismantled. We have to redistribute power away from the archetype of the all-knowing therapist sitting above the patient. SFBT requires the clinician to adopt a not-knowing stance. You enter the room without assumptions, allowing the client's actual words and experiences to guide the session, rather than forcing them into a pre-existing diagnostic box. There is a classic Zen parable about a professor who visits a master to learn about Zen. The master simply pours tea into the professor's cup until it overflows. You cannot learn anything new if your cup is already full. If a clinician enters a session filled with their own assumptions about addiction, there is no room for the client's reality. This leads to a non-negotiable axiom of the practice. The client is the undisputed expert on their own life, capabilities, and problem. You are not there to be the expert in their pathology. Your role is strictly to be an expert in the conversation of change, guiding the dialogue so the client can discover their own behavioral solutions. A session often begins with problem-free talk. The clinician spends the first few minutes asking about the client's hobbies, skills, or daily life. This acts as a form of conversational anesthesia, lowering natural defenses and establishing the rapport. This technique achieves something vital. It separates the person from the pathology. By highlighting their competencies first, we establish that the substance is the problem to be solved, not the person. When a client pushes back, traditional models often label them as in denial or resistant. SFBT rejects those terms. Instead, it views these reactions as constructed relationships between the therapist and the client, categorizing them into 3 typologies. This chart outlines the client engagement typology. First is the visitor. These are typically mandated clients who do not believe they have a problem and see no need for personal change. The clinical goal here is highly pragmatic, just keep them coming back. Next is the complainant. This client acknowledges a problem exists and is willing to talk, but they firmly believe the solution requires someone else to change, like a spouse, a parent, or a probation officer. Finally, we have the customer. This client recognizes the problem, is motivated by personal goals, and sees therapy as a vehicle to actively alter their own behavior. A primary cause of clinical failure is treating all 3 of these relationships with the exact same intervention strategy. If you demand customer behavior from a visitor, you will hit a wall. The working assumption in SFBT is that every client is a hidden customer. The clinical challenge is engineering that transition, particularly when dealing with a complainant. This flowchart maps the transformation process. We start with steps 1 and 2, join them, and delineate the goal. If a client says their only goal is to get their probation officer off their back, you do not confront that as denial. You validate it as a primary treatment goal, and you collaborate to figure out exactly how to make that happen. Next, we deploy step 3, exception questions. You ask, what are you doing differently during the times your probation officer isn't hassling you? This shifts the focus away from the officer's demands and directly onto the client's own successful coping mechanisms, which brings us to step 4. By unpacking those exceptions, the client connects the dots. They independently realize that altering their own behavior, like submitting clean tests or arguing less, is the exact mechanism required to achieve their external goal. We take a client waiting for someone else to change and guide them into actively participating in their own recovery. We engineer internal agency and accountability, and we do it without ever directly confronting their initial resistance. This pivot relies heavily on the theory of exceptions. The premise is simple: no problem happens all the time. In addiction treatment, an exception might be a single day of abstinence. The clinician's job is to ruthlessly unpack that day. What was different? Who were you with? How did you avoid using? You find the successful behaviors and you amplify them. When a client struggles to identify exceptions, we use the miracle question. It asks, suppose tonight while you are sleeping, a miracle happens and the problem that brought you here is solved. When you wake up tomorrow, what is the first small thing you will notice that tells you the miracle happened? Often, the first response is, I don't know. The clinician must hold the silence. Allow them time to think. If they remain stuck, use a what else probe, or shift the perspective by asking, what would your best friend notice about you that would tell them the miracle occurred? The wording must adapt to the patient. For adolescents, this often becomes the magic wand question. In strict religious contexts, the word miracle might carry theological weight, so you rephrase it to ask about a hypothetical perfect day. The linguistic architecture of this question bypasses the client's immediate feelings of hopelessness. Because the problem is solved in their sleep, it removes the burden of figuring out how to solve it, allowing them to instantly generate highly detailed, actionable descriptions of their preferred future. To quantify that future, we use scaling questions, typically from 0 to 10. Crucially, SFBT uses these scales to measure the scope of the solution, never the severity of the problem. We ask a client to rate their confidence or their motivation to change. If a client says they are at a 4, the follow-up probes dictate the rest of the session. We ask, what keeps that number from being a 3, to uncover existing strengths. Then we ask, what would it take to move from a 4 to a 5, to formulate small, manageable next steps. When a client experiences a severe low point or a relapse, we shift to coping questions. We ask, given how bad things are right now, how have you managed to keep them from getting worse? These tools ensure therapeutic momentum never stalls. By scaling motivation and questioning how they survive the bad days, we consistently reframe even the smallest data points as objective evidence of the client's resilience. Solution-focused brief therapy does not ignore the severity of addiction. It simply separates the analysis of a problem from the construction of its solution. We operate on the observation that studying pathology does not automatically generate a roadmap for living. In this model, the clinical tools of typology and exceptions are used to build a specific type of conversation. This dialogue, the process of co-construction, is the primary mechanism that triggers behavioral change. Map out the typologies, listen intently for exceptions, ask the miracle question, and scale their strengths. You use minimal intervention to get out of the way so the client can do the work. As Dr. Lippincott reminds his students, as future clinicians, you are not mechanics tasked with fixing broken machinery. You are collaborators, working alongside the client to co-construct a preferred future.